Thank you very much. So now for something a little bit different. This is a bit of a mouthful, this title. Today I'm going to talk less about the nuts and bolts of exactly what to do, and more about how to structure the consultation, given that the reality is you have few minutes often to interact with patients. And how can you best use that time to do something that is consistent with evidence-based behavior change, and what sort of behaviors can you cultivate in the short time that you have? These are my disclosures. Good. So learning objectives today. Again, the basic idea here: how to structure the time that you have with your patients to get the most out of the short time that you have. So, quick quiz for you to kick things off. Just by a show of hands, who in the room knows that exercise is good for you? Yeah, there's a few. Okay, most of you know. That's good. Who here advises patients who are smokers to stop smoking? Okay, good. Yeah. Who believes that they have the capacity now to follow all of the health behavioral recommendations around nutrition and exercise and so on? Who believes that they could do it if they wanted to do it? Oh, yeah. A few of you for sure. And just by show of hands, who follows all of the recommended health behaviors? Sodium, nutrition, exercise, and so on? Let's say personally. Let's get personal. Oh, we do have a couple of people in the room, but it is a minority. It's a minority. And of course, this is the problem. Even for us, we talk about patients not doing what it is that they're supposed to do. Well, we as providers often as well don't do what we're supposed to do. We know what we're supposed to do, but the reality is, as we heard from Dr. Egan's talk yesterday, this access to excess issue, healthy behavior is unusual behavior. Healthy behavior is abnormal behavior in our environment because it represents the more difficult behavioral choice. Quite simply, it's just easier not to engage in healthy behaviors. So when we think about the percentage of patients that follow recommendations, well, we know that a large segment of patients don't even fill a prescription when provided with one. And of those who do fill, you have a low overall adherence rate. So across medications, and this is true in cardiovascular medications, probably something around a 35% adherence rate overall, which is staggeringly low. When we think about other health behaviors, exercise, most Canadians don't come even close to meeting the 150 minutes of moderate to vigorous exercise during a given week. We see that with children as well, which is disturbing. And while there's been some improvements, obviously, over time as a consequence of policy change in smoking, you see that these improvements have sort of leveled off. And there's a disturbing trend among young women who are smoking for a variety of reasons. And of course, this new phenomenon of e-cigarette use, which is a really puzzling kind of question at the moment. So, and again, of course, we can look at weight, which is this, of course, closely tied to nutrition, what we eat. And you can see this slide, classifying overweight and obese as a consequence of having a BMI over 25, equal to over 25. And you can, argue with the use of BMI, but the point is that we've seen this rapid increase in overweight and obesity that approaches what we also see south of the border. So when I ask people about their concerns around bringing up health behavior change with patients, this is what I usually hear. Oftentimes, we only have a few minutes. We don't want to get stuck in a long counseling session. We may feel unprepared in terms of being skillful at delivering health behavior change intervention. And of course, we know what happens with patients when we avoid these topics is that they get a clear message that this is something that they are not to bring up, that's not terribly important. And of course, it adversely impacts their health, being the cornerstone of cardiovascular disease management. So one of the concerns around the time pressure is that if we ask patients about their health behaviors, that this will initiate long, drawn-out responses that last many minutes. Well, we know, like from a variety of studies, this is one of my favorite ones, published in JAMA some time ago. It's been replicated many times, that with open-ended questions, usually healthcare providers, physicians, interrupt very quickly. And if patients are allowed to speak uninterrupted, the vast majority of them will complete, will finish, will terminate within a minute or so. Okay? So how do we not change behavior? Just to kind of like put things in perspective, let's take these off the table. Fear-based appraisals, not particularly helpful. Who has not heard that smoking is bad for your health, that you end up with these terrible, horrible illnesses? We see them, decorating cigarette packages all over, like TV and print advertisements. So we know that fear appraisals, worked somewhat, and all of those smokers who were going to quit smoking because they were unaware of the terrible consequences of what they were doing, they've already quit. And that's left a sort of a hardened group of smokers who are not going to be responding to this. At best, fear appraisals get things going. But of course, the classic example would be someone who needs to lose a few pounds. You tell them about the horrible consequences associated with their weight. They maybe start to engage in physical activity and exercise. They modify their diet. They lose a few pounds. They don't feel so scared, guilty, or ashamed. And surprise, surprise, they start to regain the weight again. This sort of cyclical pattern, of course, leads to a well-known phenomenon in psychology known as learned helplessness. Cheerleading, or the indiscriminate use of positive affect or positive reinforcement, is again not particularly helpful. Most healthcare providers are trained in this bond alliance model. You want to stop smoking? Fantastic. Let's get going right away. We'll put you on NRT, bupropion, varenicline, let's go. I know you can do this. Again, not particularly helpful. My knee-jerk reaction to someone who comes in and says, I think maybe it's time for me to stop smoking, is to ask them, why? Are you sure? Is this really a good time? Rather than to jump right ahead. So let's talk again about then how to change behavior successfully. And this requires like an interesting shift, which is very difficult in the context of a standard consultation. The shift involves going from the teach and tell instructional expert advice giver, moving more towards a change-based relationship based on collaboration and empowerment. So, of course, what we know is what the patient does in between the meetings with you is far more important than what you do in the context of the consultation, and you want to set them up for success. One simple strategy to do this is just to come up with a structure for the time that you have. If you only have a few minutes, there are a few things, arguably, that are consistent with evidence-based behavior change that you could do. And so this isn't a rigid, kind of rigorous scheme, but these are some of the key things that are involved in successful health behavior change. First, setting an agenda. 2, assessing readiness. 3, reflecting and reinforcing, and 4, implementing or securing some commitment to the behavioral plan. So let me run you through how this might roll out in a few minutes with a patient. So to begin with, setting the agenda, very important. Rather than kind of launch into what you feel is ultimately the most important thing to discuss when it comes to adherence, health behavior change, and so on, to take a moment to note to the patient what it is that you'd like to talk about, but also to have some comfort with swimming around a little bit of uncertainty to determine what it is that the patient wants to talk about. Because, of course, if you see their medication adherence as being the most important issue that you must talk about, and the patient sees it as the least important issue that they want to talk about, there's a real mismatch there. So again, important to ask permission of the patient, of course, like, is this something that would be okay if we talked about it, and to ask if there is something else, so that you can also structure the time, and don't, in the last 10 seconds of a consultation, have to deal with someone who says, oh, and by the way, I haven't been taking my medication, or I'm not doing what it is that you told me to do with respect to diet or exercise. You want to kind of know that up front. So to make use of the time, arguably setting an agenda important. Step number 2, a readiness assessment. You can ask a few simple questions to get a sense of where to go with the health behavior change. So, the classic readiness assessment, 4 questions. Do you consider your current behavior to be a problem? Does the person, in other words, accept the diagnosis? Do they accept that their behavior has a consequence? Number 2, are they distressed by the current behavior? This gives you some sense of the kind of affective component. Of course, like if people are stressed out about what's happening with their health, yes, that interferes with chronic disease self-management. Are they interested in changing the behavior? important to know in terms of like, where they are along the readiness continuum. And are they ready to change, will help you with the goal-setting action plan. So 4 basic questions. Once you determine where they're at along this readiness assessment, you can think of the next step along a kind of traffic light analogy. You've got some people who are all set to go, and there you can talk about behavior modification, about what it is that might be helpful and so on. Fantastic. Many people, of course, will be ambivalent about health behavior change. That's normal. For people even who have quit smoking, it's not like they're going to tell you, I never benefited from that at all. I don't know why I was doing it. It was crazy. There is a benefit. There's many benefits from smoking. There's several. There's managing weight. There's stress management. They're addicted, and so it reduces symptoms of withdrawal. All kinds of good reasons to stop smoking. And sometimes, again, highlighting this ambivalence with the patient. In other words, identifying why they engage in the behavior, why they might not want to engage in the behavior, and tying it to their values, their reasons for change are most important. Most healthcare providers will do a couple things. They'll talk about the disadvantages of engaging in the status quo and the benefits of change. But what they don't do is talk about the benefits of remaining the same and the disadvantages of changing. And again, that's important to highlight this discrepancy between what it is that they know is right and what it is that they're doing, and move them along the continuum of change. Of course, even if someone comes in and they indicate that they have no intention of changing, the conversation should not end there. This is actually a starting point, and perhaps the goal shifts to having the patient actually return, to tell the patient that they might be interested in thinking about some of these issues, to ask them about the reasons for and against, why they think it might be important to change, what it would take for them to change, how important it is for them to change, what would it take to improve the importance or confidence, those sorts of questions. And to just simply reflect that back to the patient, selectively, highlighting the reasons that they identify that might be important for change. So we've got setting the agenda. I have like assessing readiness, and then a reflect reinforcement step. Of course, the idea here with the reflection and reinforcement is to get the person to identify why it is important for them to change, rather than to assume that it's because of their cardiovascular risk. If a patient wants to lose weight because they want to look great at the beach in their bathing suit, that's fantastic too. Go with it. And of course, if you assume why they might want to change and you miss the mark, that's not helpful for promoting change. So instead of the teach and tell lecturing expert advice giver, it's important for you to lose weight, you have to stick to the DASH diet, you need to check your blood glucose regularly. If not, terrible things will happen. Can you do this for me? It's very important. You have a family, you need to take care of yourself, and so on. The alternative approach would be to ask questions, to have the patient do most of the talking around the reasons for why they might want to change. And again, make no mistake, in survey after survey, Canadians understand they should move more, and that they should maybe eat less or differently, that they should stop smoking and so on. But of course, very difficult to do so. With the reflect reinforcement stage, there is this kind of reinforcement where you kind of paraphrase what the patient says, you feed back to them what it is that you've heard, and you allow the patients again to problem solve, rather than when you think, gosh, this person's having a problem with their with remembering to take a particular medication. I'm sure like blister packing or putting up a note on the refrigerator, that's what's going to be most helpful, so I'll launch into that. Well maybe, maybe not. But the first step could be to ask the patient what they've tried, what they think would be helpful, what other people have told them would be helpful, and then if you do have some expert advice to give, to at least ask for permission. Would it be okay if I shared with you some strategies that have been helpful with patients with similar difficulties? And then to offer them not a simple, singular, molecular solution, but a menu of possibilities, and then ask them what they make of that. Do they think that any of that would be helpful, or none of it would be helpful? And go from there. Finally, there's the implementation of the behavioral plan stage. And again, this is sort of like the reflection. It's summarizing. It's a special kind of reflection. And what you do is you review with the patient what it is that you've spoken about and some of the solutions that have been that might possibly be helpful. Even better, with a little bit of practice, you can get the patient to do this work. arguably the patient, when it comes to this kind of collaborative empowerment stage of the consultation, should be doing most of the talking, all of the talking. So you ask them what they've taken away, what they feel is best for them to do, and so on, to get a sense as well of where they're at, and not to fall into the trap, of course, of thinking you did a wonderful job with the patient, telling them about what they need to do, and they're walking off and not adhering. So, of course, again, if you have these suggestions for them to add to the end of the consultation, to, of course, ask for permission, and then offer them some advice, and then ask them again what they make of that. That's the illicit provide elicit model. Important for me to note here that behavior change requires changing behavior. Now, this is an obvious statement to make. However, when we think about health behaviors, some people talk about it and they sort of skip the intermediate steps. They talk about weight loss, losing weight. Well, actually, that's not a behavior. Okay, the behavior would be the dietary modification piece, right? And so we need to very clearly define behaviors associated with achieving the outcomes. Okay, adhering to medication is not really the intermediate kind of behavioral steps, and we can't sort of forget to not skip over that. We want to know with the patient exactly what they will do, what's under their control, given the context of their lives. And of course, with most patients, they want to minimize the impact of chronic diseases on their life. They want to minimize the footprint. So you might have all kinds of wonderful ideas that will maximize the imprint, and most people, want to make it as minimal as possible. So how do you do this? You ask them, what exactly are they going to do? When is it going to actually happen? Where are they going to do it? What are they going to need to make it happen? And perhaps an often forgot but very important question, who is going to help them achieve this or provide them with some support? Okay, so this is a little bit like the SMART goals that many of you are familiar with, but a little bit more concrete in terms of the kinds of questions you can actually ask briefly with the patients, or some of them, depending on your time, interest, and skill level. So again, in terms of structuring the consultation, arguably, this is one way to do it: setting an agenda, asking about readiness, reflecting and reinforcement, and the behavioral strategies, securing that commitment. So, of course, we know there are all these things that people are supposed to do: exercise most days of the week, reduce their sodium, limit their caloric intake, and so on. But again, it's I think important for me to point out that what we want to do with the behavior in these with the patient in these consultations is to also shape their behavior. Okay, so it's important to point out that something is better than nothing, more is better than less. And if you have a patient who's completely sedentary, for example, and you want them to start increasing their physical activity or exercising, oftentimes we think, well, target is 40 minutes a day, most days of the week, moderate to intense physical activity. Arguably, that might be a mistake, and you might want to adjust towards a very realizable goal the patient is willing, ready, and able to complete, and then to increase the amount of activity in a stepped fashion. Oftentimes people, when they think about shaping, they forget that they shouldn't go from walking for 10 minutes to, great, you've got that, now let's up it to 40 minutes. You want to use equal kind of interval increases in terms of modifying a behavior to develop that habit. So the other important point here, of course, we want to move away from that expert advice-giving, teach-and-tell mentality to this collaborate and empower mentality. So the question is less, do you want to take care of yourself? I don't understand. And more towards, why do you want to? How hard are you willing to work? How willing are you to make choices that might increase the burden temporarily to delay that gratification that we're all sort of seeking to improve your health in the long run? So very quickly, there is evidence for these approaches. This is not something that I've identified or come up with. This is based on 40, 60 years of health behavior change research, basic kind of behavioral science stuff. I don't have time to kind of get into this today, but I thought I would throw a slide in for just for a reference. There are also, of course, based on your interest, a number of very well-established evidence-based strategies for shaping behavior. Self-monitoring, stimulus control, cognitive restructuring, and so on. Again, we don't really have time to kind of talk about this today, but based on your interest, this is something that, again, works to help change behavior. Here's my contact information. Thank you very much for allowing me to speak with you a little bit about structuring the consultation today. And I think we can move on now to the Q&A portion of the symposium. Thank you.